Good morning, everyone. Welcome to our ninth annual research symposium. Our center began as a concussion-focused center about 20 years ago. Initially, sports concussion was prominent, but now we are reflecting all kinds of concussions, all mechanisms today, especially with intimate partner violence, pediatric concussions, work-related concussions, etc. We look forward to this, and in fact, we've been planning it for about a year, and we're very grateful to those who have helped put this across. I especially like to acknowledge our research manager, Mojgang Kodadadi, and thank you to Kim Hussey and Christian Peterson for the communications and technical aspects of this program. And thank you to the two chairs who have been both very busy, both planning and executing this program today, Carmela Tartaglia and Robin Green. And this is a special time for Robin, who was just made a full professor in the Department of Psychiatry. So we're all very pleased with that. We also extend our support today to the Ukrainian people who are being murdered by a despot, Vladimir Putin. And the issue of trauma and prevention of trauma is always very much on our minds at our concussion center. And so dealing with this type of trauma is just so discouraging. But research is coming along very well in concussion. When you consider the awareness of concussion and the amount of investigation of the concussion problem, it's really heartening that worldwide we've seen so much effort being made to combat our mini war against concussion. So I'd like to turn this over to my colleague, Carmela Tartaglia. Carmela is an associate professor at the University of Toronto. She received her medical degree at McGill. She's been working in the cognitive behavioral clinic at Toronto Western for a number of years. She's become an expert in concussion. She's the holder of the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And I will ask her to take over in just a moment. I have some housekeeping notes to communicate to you. Please use the Q&A for your questions, and use the chat to indicate if you have any technical issues, and someone will be there to help you. During the breaks, please take a look at the poster presentations, and a link to the posters will be put in the chat before every break. The sponsors for this event are several, and I'd like to acknowledge them. The Canadian Football League, which has been very important in our growth and development over the years. The Canadian Football Alumni Association similarly has played a role in helping our research. The National Hockey League is a sponsor, and the Ontario Brain Institute is a sponsor, along with Hockey Canada. So thank you to all of those people. And now over to you, Carmela.
Thanks, Charles. It gives me great pleasure to introduce our next speaker, and I hope that at some point we'll be able to all meet in person. This is Dr. Hana Rytter, who's an associate professor in cognitive neuroscience and neuropsychology at the Department of Psychology, University of Copenhagen, Denmark, who's going to talk to us about return to work after concussion. She has received her original training as a psychologist at Palacky University in the Czech Republic, and then moved on to the neuroscientific studies. She received graduate training at the Unit for Cognitive Neuroscience at the University of Copenhagen and the Stroke and Neuroplasticity Laboratory in Newfoundland, Canada. For the first decade, her professional interests have revolved around the field of concussion, where she solves both clinical and academic tasks. Since 2019, she's been appointed to head the Danish Concussion Center, established under the auspices of Danish Ministry of Health. The center is a national resource conveying current evidence-based knowledge on concussion and generating new data in the field in close collaboration with academic and clinical milieus across the country. Lately, she chaired the preparation of the Danish National Clinical Guidelines for Non-Pharmacological Treatments of Persistent Post-Concussion Symptoms, published in 2021. And it gives me great pleasure to introduce Dr. Hana Rytter.
Thank you very much for a lovely introduction, Carmela, and I will go ahead sharing my screen. Like this. I hope I'll hear from you in case something is not working right. Otherwise, I just proceed and assume that everything is just as it should. So everything what should be said about me has already been said. So I will just go ahead with the next slide. Indeed, I bring you today greetings from the lovely Scandinavia in the north of Europe. Specifically from the smallest of Scandinavian countries, as you see here at the very bottom of this picture, Denmark, with a population of approximately 6 million people. And I'm right now sitting in Copenhagen that we have here at the island called Zealand. In the very eastern part of that island, we have Copenhagen. If you were here visiting the city, you would probably be strolling through the colorful new harbor, as you see on the picture, or you maybe daydream with Little Mermaid, or think of some of the other stories that Hans Christian Andersen shared with the world. So that was just a little bit about what, the setting I'm going to talk about. I'm going to present Danish data on research regarding return to work, and I'm very pleased to be able to share that with you. So after a short introduction, I will go ahead telling you about these studies where we used the national registers, and we have looked at both short and long-term follow-up in persons who receive the diagnosis of concussion. And we also looked at the pre-morbid risk factors relative to return to work. Then I'm also going to share a little bit about qualitative studies with respect to what facilitates or, on the other hand, acts as a barriers when people with concussion try to return to work. And then just tell you a little bit about what we do right now, and there should be some time for questions. So, return to work should in principle be easy. Concussion has a good prognosis and most of the patients experience fast and spontaneous recovery. So that's very good. However, if you are not the lucky one who recovers within these few weeks and you start experiencing prolonged symptoms, it quickly becomes a struggle. If you have persisting symptoms, you will not be able to resume your daily work and of course other things, and you will indeed meet a multitude of obstacles while you are simultaneously tackling the symptoms. In Denmark, the patients with prolonged symptoms often find themselves at loss in a health system that lacks knowledge of the condition itself. The treatment trajectory for these patients is often lengthy and inefficient, and that's what we try to illustrate in this figure. but still most recover without problems. So we wondered if we track a lot of patients with concussion diagnosis over a prolonged period of time, will we be able to see the effect of concussion regarding work and return to work, both short-term and long-term? So this was the outset why we designed the studies in which we used the national registers in order to investigate the question. So the registers in Denmark, we have access to high quality registers of both labor, market attachment, and health. So these were our data sources for the couple of studies or 3 studies that I'm going to mention. What binds everything together is this so-called CPR number. This is a unique personal identification number that is assigned to all Danish citizens at birth or upon immigration to the country. Our cases for the studies were then identified through the Danish National Patient Register. This register contains information on all inpatient and outpatient contact in Danish secondary care, that is in the hospitals. So the data that I'm going to be presenting are exclusively showing the picture of those who have been through the hospital. We are not, as it is right now, able to track what is going on through general practice. So the Danish National Patient Register, all the data on patients that go through the hospitals, and notably it codes each contact the patient has with the system with ICD-10 diagnosis codes. So we were able to get the codes for concussion. Availability to the labor market was defined as gainful employment or if people were receiving unemployment benefits but were actively seeking jobs. So they were, in other words, available for the job market. This availability for the labor market assessment, this availability for labor market is assessed through this register, the Danish Register for Evaluation of Marginalization. The name is not important. We will just call it a DREAM. This register contains weekly information on all individuals that are receiving any social public transfer payment. So if you are gainfully employed or actively searching for a job, you will be marked in the register with a particular code. So we know that you are not receiving any social transfer payment. We also track data on pre-injury income from the Income Statistic Register, information on the highest achieved education from the Danish Education Register, information on cohabitation status and ethnic origin from the Danish Family Relations Database, and we use the Population Register to get our controlled sample. In general, we looked at the pre-injury illness burden that we measured by using the Charlson Comorbidity Index, and we also controlled for pre-injury neurologic and psychiatric disease. This slide is to give you an insight into design of our studies. So we have had 3 periods of time that are important to mention. The period from 2003 to 2007 was our inclusion period, 5 years where we were including the patients who got the diagnosis of concussion. And then we looked at the labor market attachment of those cases for up to the next 5 years. So that would be in the 2008 until 2012. We got all those who received the ICD-10 concussion diagnosis, that is the S06.0 code. They had to be 18 to 60 years of age. And as I said, they had to be either working or available for the labor market. We excluded those with severe head trauma during the inclusion period, and those who had severe head trauma or concussion for up to 5 years prior to our inclusion period. We further also excluded those who were staying outside of Denmark, and that will be both for the inclusion period and for those 5 years prior to our inclusion period. And then we had our control cohort. The cohort was randomly selected from the population register. Controls had similar inclusion criteria as the cases, but they had no diagnosis of concussion during our inclusion period, that is between 2003 and 2007. Here are our outcomes. We selected as our primary outcome, we selected a broad outcome that was telling us that the patient was not attending ordinary work. Here in the upper part of the figure, you see all the different types of social transfer payments that you may be receiving. Denmark is a welfare state, so a lot is done to support people during unemployment. But all of these could be, in any of these cases, the patient would not be working, and this is what constituted our primary outcome. This was this was indicated by any entry in the DREAM register. Could be unemployment, could be benefits related to the health condition, but also benefits unrelated to the health condition. It could be social benefits that were granted. It could be benefits due to both short-term and long-term sickness, and of course, it could also be death as an outcome. So if there was no DREAM entry, it was assumed that the subject was gainfully employed or self-supporting at the time where we included the person in the study. The secondary outcomes are noted here by 2, 3, 4, and 5. So the set of secondary outcomes was defined increasingly narrower than the primary outcome and focused on attachment to the labor market due to that was related to the health condition. So let me present some of the results. So this slide shows the data from a cohort that was nearly 40,000 people. About half was with concussion, 18 closely to 19,000, and then we have had a control person to each of our concussion case that was matched on age and sex and were in the country they live. We saw, we tracked them throughout the 5 years, as I mentioned, but looked also more specifically what was the situation a half a year after they had received concussion diagnosis, a year, 2 years, and then again 5 years. Here you see that as time progressed, the patients with concussion compared to our controls, the patients with concussions are the darker bars here, and our controls are the light blue bars. So patients with concussions, they compared to controls had a overall higher increase in not attending ordinary work from, if we looked at index date where we included them in the study compared to 5 years later. So at the index date, about 32% of concussed patients were not attending to work, whereas at 5 years, the number was 43%. And when we looked at controls, it would be about 27% who were not attending ordinary work, and that number was 29 or so percent 5 years later. As I said, it may look, if we look at the index state here, it may look that there already at the index state was a difference regarding our primary outcome between our Concussion group and our control group. That was the case for the crude model, where we did not control for potential biases, but in the ingested model, we controlled for other factors that could explain the difference, such as socioeconomic factors, other comorbidities, psychiatric comorbidities. And when we did that, then there was no difference between our cases and our controls at the index state. And then during the 5 years follow-ups, the odds of not attending ordinary work, they increased by, at 5 years, the odds of not attending ordinary work were about 50% higher, 54% to be precise, in our Concussion group compared to controls. So the adjusted odds of not attending ordinary work, they remained increased by 30 to 50% during the follow-up period. And this strongly supports that concussion was the incident leading to not returning to work, that it was not the other possible factors that could explain it related to the socioeconomic situations or comorbidities of the patients. Then regarding our health-related, the secondary outcomes, the overall prevalence of health-related benefits was significantly higher for the patients compared to the controls already at the index state, and that is in accordance with what we know about this patient group. But we see that the difference again with how much that is how much health-related benefits they received. This increases over time. So the odds, when we looked at 6 months after concussion, were 6% in our control group versus 18% in our Concussion group, whereas at 5 years it was 9% in the control group and 24% in the Concussion, and we again saw elevated odds ratios for receiving health-related benefits. The same story is repeated when we looked at other secondary outcomes, such as the limited attachment to the labor market. Again, we saw increased odds of receiving other social transfer benefits that were not health-related, elevated odds of 1.39. And when we also looked at the permanent exclusion from the labor market, that is patients that would end up receiving some sort of a retirement, premature retirement, we saw actually quite an increase from 1.5% to, that was the case in our control population, to 5% in our Concussion population, and the odds of leaving the labor market 5 years after concussion diagnosis were more than double. As you see, it is 2.59. So we did see that receiving concussion diagnosis has an influence on the labor market attachment, not the least when we look at the long-term data. Now, we were wondering about a number of things. Besides other things, we were wondering what are the risk factors for premature labor market attachment change? Can we say something about if people live together, or how educated they are, or if they are not Danish, if they have other ethnic origin, with respect to what age they have, what gender they are, and if they have any psychiatric or somatic comorbidities? Are these the factors that can predict the labor market attachment, both short-term and long-term? Regarding risk factors, as you probably know, there is a vast body of evidence studying the risk factor for prolonged course of the disease, for prolonged symptoms. Risk factors for labor market attachment are less studied. And just to emphasize, we did not know how many of our cohort actually developed the prolonged symptoms. We only know of these 20,000 or so patients that they have once during those 5 years received concussion diagnosis. This is why we decided to look more specifically at the risk factor for labor market attachment. The current studies that are available are mostly based on self-reported data, or they are restricted to short-term follow-ups. So we try to indeed exploit the fact that we have had access to these high-quality registers where we could track patients for quite a long time. Yes. So let's have a look. What of these factors that are mentioned? Cohabitation status, education, ethnicity, age, gender, and either psychiatric or somatic comorbidity, which of them were showing higher odds for not attending ordinary work? That was again our primary outcome in the study, looking at if people were attending ordinary work or not, either 6 months after concussion, that would be the short term, or 5 years later. And we've seen that with respect to cohabitation status, that is, if people were living alone or with someone else, the odds increased for those who were married or cohabitant. They would be less likely to be at work. They would have higher odds for not being in ordinary work, as you see. With respect to education, we have, perhaps a little surprisingly, we can discuss it later on, we've seen a long-term effect or long-term impact, especially in those who had the highest education, that is those who were past what's called the college, entering universities. We see that in those 5 years later, after concussion, the odds for not returning to work, odds for not being in ordinary employment were more than doubled. So that was quite a significant finding. Also for those who were not of Danish origin, those who were born abroad, they had elevated odds, almost double for not attending ordinary work in the long term again. And age-wise, we had categorized age into 4 different groups, those under 30, and then those being in 30 to 39, 40 to 49, and 50 to 60. And as you see, the odds for not being in ordinary work in the long term, 5 years, were highest in the younger group, that is those being at between 30 to 39, and the second most elevated odds for not being in ordinary work were in the very young group, those who were still completing their education or just getting a grasp of the job market. Whereas in the older age groups, the odds of not being in ordinary work were decreasing. And then the last category where we had seen elevated odds again in the long term at 5 years post-concussion were with those that had more than one somatic comorbidity. Quite surprisingly, we did not see elevated odds for not returning to work in those who had psychiatric comorbidity. That was something we expected, but we did not find it in the data. So based on these two studies, we conclude that concussion is associated with a greater prevalence and risk of not attending ordinary work, both short and long term. It is associated with long-term sick leave and reduced workability. And we have seen that concussed individuals are much more likely to get a limited attachment to the labor market, or even permanently leave the labor market. And those groups that are at risk long-term are especially the younger adults and adults with longer educations than persons from ethnic minorities, persons with somatic comorbidities, and married persons had also elevated odds for not being in ordinary work long term. Yeah. There were many, yes, just to, if anyone should feel like reading more about these studies, they have been published, and I gladly also send you the link if you contact me or contact the organizing committee of this conference. Then we also had some questions regarding what is going on with respect to some other parameters. When we looked 5 years after concussion, parameters such as do people, if they are married, are they still married? Is there an effect on marital stability? Can we see because we saw that younger people were challenged and were like a group at risk, do we see an effect with respect to how well they enter and finish their education, so with respect to the academic achievement, and also would we be able to see effects regarding income and in general the socioeconomic status 5 years after concussion. And these results were summarized in this study. The design of this particular study was in many ways similar to the one that I already mentioned. There were a few differences. Obviously, our outcomes were not the labor market attachment per se, but we looked specifically at changes in marital stabilities, income, and socioeconomic status and academic achievement. Again, we created a cohort of patients with concussion, 18 to 60 years of age, but this cohort could be also out of the labor market because of other reasons, or could be students who have not yet entered the labor market. So we did not have it as a criterion that the concussed patient had to be working or available for the labor market. The cohort was somewhat a little bit bigger. It was a total of 40, close to 46,000 individuals. Of those, about 24,000 with concussion and 22,000 controls. Again, we excluded those with severe head trauma, those that had severe head trauma and concussion for about 5 years or up to 5 years prior to concussion, and again, those that were living outside Denmark. Here we also, besides matching our controls regarding age and gender, we did not match them here where they lived, but we did match them with respect to which municipality was their home municipality. And then we also matched them regarding labor market attachment. So for every concussed individual that was not working, we would find a control person that was not working, etc. Yeah. I will not go into the details regarding the results of that study because I have some other things I'd like to share with you, but we concluded based on the data from this study that at 5 years post-trauma, we did again see the impact of concussion. Again, remember that we do not know if or how many of our cohort developed the prolonged symptoms, but we did see that concussed patients had an impaired chance of finishing education, so they were less likely to finish the education that they had started. They were also less likely to enroll in an education, and all that would be beyond the difference in prevalence at baseline that we would see. Patients, they were, in other words, less likely to study and to finish their education. They were also less likely to experience advancement with respect to their career. So we looked at the odds of transitioning from being, for instance, worker to becoming a manager, or becoming a leader. So the odds for that would be lower in the concussed group compared to the control group. And again, this was beyond the differences we saw at baseline. So we indeed conclude that the academic achievement and socioeconomic status were affected by concussion. We did not see any effect on marital stability in this study, and we also did not see effect on income. Yes, so these were the data that looked at, I like to call them the helicopter perspective. We got a huge amount of people into our study, but we did not really know anything in details about them. And we definitely did not know how they experience the situation of being with concussion and trying to return to work. So that was also another important perspective that we would like to investigate. And in order to do that, we had to go for a qualitative study. Here we examine the patient's experiences of the relevant actors that they meet. Patients with concussion, they go through different phases, including, of course, both the acute treatment, and they return to home. Then they have the sick leave. Perhaps they, as I said in the figure where I showed the challenging life of person with persistent symptoms, they go for a number of different treatments. They try to reintegrate to the community. They try to reintegrate to their job and return to work. Regardless how they do that, they will meet a number of different actors, and in order to succeed returning to work, it is most likely very important that the actors across the field somehow cooperate. At least they have to cooperate with the concussed patient if they do not cooperate across the sectors. So the relevant actors could be, of course, the worker, the patient itself, but then all the healthcare providers, such as general practitioners, all sorts of other therapists, such as physiotherapists and occupational therapists, neurologists, neuropsychologists, and other. Then another group of important actors would be employers, their supervisors and managers, but also their co-workers. Then the government and society, the way our system is managed, what are the let's say, the economic and legislative systems and incentives. How is the municipality supporting the concussed patient or not supporting the concussed patient when trying to return to work? That would be another group of actors. So as patients with concussion attempt to regain their work capacity, they will meet all of them, and the cooperation between these, we hypothesized, would be of great importance, as it either can facilitate or act as a barrier when you're trying to return. So we have performed this qualitative study with semi-structures in-depth interviews, and we used thematic analysis with a phenomenological, hermeneutical approach to analyze the data. We have included patients with concussion that were referred to an interdisciplinary rehabilitation clinic, and about half of those in our sample would receive treatment at the clinic, and half of those would receive the treatment by the municipality. They were not granted the treatment by the clinic, but they were most likely granted other type of treatment. The trajectory up to the point where they were referred to the clinic would be similar in between these two groups. And we were not in this particular study interested in researching the difference between those that were granted different types of treatment. What was important was that all patients were diagnosed by a physician. They were 18 to 60 years of age. Again, everybody was gainfully employed when they got their concussion, but we talked to them that, the time after, how long time there was since they had suffered concussion until we talked to them, that varied between 1 and 4 years. We excluded those who had neurological, physical, or psychological disabilities, and those that were not Danish speaking. From this research, 3 main themes emerged with respect to what acts as a facilitator or a barrier for patients with concussion when trying to return to work. So one theme was related to the workplace and the relationship that the patient has with the employer, but also co-workers. The second theme was related to the role of general practitioner, and the third theme was related to how municipalities run the cases, how municipalities help the cases getting back to work or not really. So let me elaborate on what was actually either a barrier or a facilitator. So when we looked at the workplace, participants described sickness, absence, post-injury lasting for months, some of them for years. Some of our participants did not manage eventually to return to gainful employment, but all of them had close contact to their workplace. The workplaces try to use different strategies to support, but so if the workplace did not use these strategies, such as decreasing amount of working hours, or if the workplace was not able to modify the working conditions under which the patient was working, for example, provide an office where the patient could solve the task undisturbed, or if there was not support from the co-workers, that would act as a barrier. For instance, a participant described some challenges regarding his employment in a small company with few employers. He did not want to stress colleagues. They already had very many tasks. So even though his colleagues were sympathizing with his condition, he decided to postpone his sick leave, and he would be working through, even though he had been he has had a lot of these post-concussion symptoms. So it was very difficult for him really to take whatever he needed and not to put extra amount of work to his co-workers. So on the other hand, flexible working hours, being able to work from home, modified job description, supporting and understanding co-workers. We had a case where the co-workers would drive the patient home, or the co-workers would say, well, now the amount of hours you are supposed to be here is over, go home, we don't want to see you here more. All this was experienced as a facilitator when trying to return to work. The other important theme was the role of general practitioner. General practitioner is the person within the healthcare system here that is responsible for management, treatment, and referral to rehabilitation for patients with concussion when they are after the acute phase. So if you have been, even if you have been through the hospital, you would not return to the hospital, you would only go to your general practitioner if your symptoms do not disappear spontaneously. As a matter of fact, absolute majority of our patients here in this sample experience general practitioner more as a barrier than a facilitator. So very often they would experience that the general practitioner was not able to offer them any treatment, and they were not able to refer them. They would experience that whatever feedback and guidance they got from the general practitioner was not necessarily individualized, not necessarily relevant, sometimes the patient, him or herself, had to come and tell general practitioner, well, this is what I had heard is a possibility. Can you help me with that? So the participants felt that they were actually the gatekeeper for their own treatment and referral rather than the general practitioner. On the other hand, those about a couple patients from our sample who experienced general practitioner as a facilitator experienced that the general practitioner was able to help them further on with respect to referrals to relevant medical specialists. In due time, they were helping them to get the return to work plan established. They were taking active role when talking to the municipality and the employer. They helped them to indeed get the modified working conditions realized in their workplace. And the last theme was the theme related to the municipal management. Sorry about that. Municipalities are that's the instance or the body of officials that you are to go through when you need some training and rehabilitation, but they are also the ones who are running the job centers, who are supposed to help people out when you have lost your job and you are looking for a new one. But municipalities often, or the case managers, which are often social workers in the municipalities, would use a lot of meetings and follow-up assessments. These were indeed experienced as a barrier because they were too frequent. They were experienced as impersonal and unnecessary. Sometimes the patient would feel that they had to advocate for their condition as it was. They experienced or they felt as if chased by these follow-up assessment. There was nothing else they would like rather than being able to return to work. Nevertheless, this was not their experience. That they did not understand. They did not experience that they would be supported and understood by the municipality, and that they rather met more like distrust and lack of continuity, planning and knowledge from the municipality, and that, of course, was a barrier. In case municipalities were able to refer the patient to interdisciplinary rehab or some other type of specialized concussion treatment, that was indeed experienced as a facilitator, something that that helped. So based on this study, we concluded that there are a number of important factors that can either facilitate or act as a barrier for returning to work. It is important when we are to talk about it from patients' perspective that they are helped to get a gradual return to work with adjusted working conditions. A lot of emphasis and focus should be on the collaboration with employer and colleagues. We need to improve the level of professional knowledge about concussion, even among healthcare professionals. And we also need to improve the knowledge about referral options among healthcare personnel. And it is what helps is the individualized, personalized follow-up, both by municipalities and other health and general practitioner and other healthcare professional, timely referral to specific guidance and treatment. Yeah, I have had a great team to help me with carrying out this research. So I would also like to express huge thanks to all of those who worked with me. The names are spelled out on the slides, and we have received generous support from a number of different foundations and institutions, and they are also mentioned here at this slide. Here at the very end, I would like to mention that we continue our effort with respect to figuring out things about return to work in patients with concussion. And currently we are carrying out a study where we examine what types of work-related initiatives are actually present at the Danish workplaces when it comes to people who are suffering long-term post-concussion symptoms and who try to return to work. And we would also, in this study, like to examine the level and quality of knowledge about concussion among the employers. And we would like to figure out what knowledge do they need in order to support people with concussion better when they try to return to work. This is a national online survey. We are just in the recruitment period. We are recruiting persons that have prolonged post-concussion symptoms. We say more than 4 weeks, but on average, it would be more than 6 months. And some of them would be even more than 12 months, but they are employed and so the persons with these post-concussion symptoms, they were employed at the time of concussion, and they have an employer to return to. They will be that's going to be one source of data, and the other source of data will be the employers to the recruited persons with long-term symptoms after concussions. That will also answer actually a couple of surveys. One is going to be focused on return to work per se, like after I've been sick, now I'm trying to resume my work and how is it going? And the second survey is going to be more focused on work maintenance, like being able to maintain the work. So not only returning and being able to be at work for the first couple of months, but being able to stay employed and what can be done in order to support that sustained employment. I hope that you'll find our results interesting, and thank you very much for your attention and for listening to my weird accent from the capital of Denmark, Copenhagen.